Segment 1, Herpes simplex virus. Primary herpetic gingivostomatitis. Imagine a 4-year-old brought in by a parent. The child is miserable, 38.5 degrees centigrade, won't eat, won't drink. You open their mouth and every surface is involved. Gingiva is red and puffy. There are small ulcers across the buccal mucosa, tongue and hard palate. The parent says it started 3 days ago and is getting worse. This is primary herpetic gingivostomatitis. The pathogen is herpes simplex virus 1 in over 90% of oral cases. It is transmitted by direct contact, including asymptomatic shedding. The peak age is 6 months to 5 years, but adults can present if they are seronegative. The clinical picture is same. The keyword for oral distribution is pan-oral, which means it involves gingiva, buccal mucosa, tongue, hard palate and lips. If the involvement is posterior only, involving tonsil, soft palate, think herpingina, not primary herpes simplex virus. The systemic illness distinguishes this from most other oral conditions. Fever over 38 degrees, malaise, bilateral submandibular lymphadenopathy, and poor feeding in children. The gold standard investigation is PCR, polymerase chain reaction, viral swab from the vesicle base. This is not a Tzanck smear. The Tzanck smear is outdated, non-specific, and also positive in varicella zoster virus infection. It cannot tell you which virus you are dealing with. Now I'll talk about the 72-hour aciclovir rule. Aciclovir is only beneficial if commenced within 72 hours of the symptom onset. After 72 hours, antiviral have no proven clinical benefit. The answer becomes supportive care only. Paracetamol 1 gram every 6 hours as per TGAN1, chlorhexidine 0.2% range. The dose when aciclovir is indicated is 200 milligrams 5 times daily for 5 days in adult and older children, with weight-based dosing in young children. Valacyclovir 500 milligrams 2 times daily for 5 days is an alternative with higher bioavailability. One drug that students consistently misidentify is valacyclovir. They assume it is different, more potent drug. It is not. Valacyclovir is an 𝗘𝗏𝗍𝗂 prodrug of aciclovir. After first pass metabolism in the liver, it becomes aciclovir. The mechanism is identical, activated by viral thymidine kinase, then inhibit viral DNA polymerase. The only advantage is higher oral bioavailability. Approximately 55% versus 15%, same drug class, same mechanism. This is directly tested as a drug class confusion trap. One absolute contraindication is systemic corticosteroid in HSV infection. Corticosteroids promote viral replication and worsen the disease. This is the single most dangerous wrong answer for this condition.